So how do we give radiotherapy? What are the guidelines which we follow when we plan a patient for post-operative radiotherapy? So this was a very good paper which was published in 2018, which tells us how should we do the target delineation in these patients. So since you all are from surgical stream, I want all of you to give us details regarding the pre-operative imaging, pan-endoscopy reports, intraoperative findings, and the final pathologic result should be available to us in order to delineate the target properly. All patients who are taken up for radiotherapy, they undergo a planning CT scan with IV contrast in a 4 to 5 point fixation immobilization device. Then we co-register your pre-operative diagnostic CT scans or MRI scans with the treatment planning CT scan to recreate the pre-operative tumor and the nodal gross tumor volume. So all the pre-operative findings, scan reports, your intra-op findings and final pathology reports are very, very important. So every file should have all those reports available. Then once we recreate the gross tumor volume, then we mark clinical target volume. Clinical target volume includes the primary and the nodal tumor bed with a suitable margin to account for the microscopic spread. As when you do the surgery, you take a certain margin in order to clear the tumor. Same way, we also create a clinical target volume around the gross tumor, the pre-operative gross tumor and gross nodal tumor in order to give a certain margin to account for the microscopic spread, pathologically involved nodal levels as well as other areas at risk. Then here also we divide two CTVs. CTV1 is a high risk CTV, which is generally 10 to 15 mm is generally recommended for the CTV primary in post-operative setting because of the uncertainties in defining tumor bed following resection. And nodal CTV1 is usually a margin around the gross tumor, pre-operative gross tumor node with a margin of 10 mm. Prophylactic or elective CTV should include all at-risk uninvolved nodal levels, which will vary according to the site and electrolytic of the primary tumor as well as the extent of neck dissection. And then we give a planning tumor target volume. So these are the guidelines which we also follow. Like if there is a unilateral treatment for lateralized tumor, and if it is PN0, then electively we take ipsilateral level 2 to 4A, ipsilateral level 1B if there is a extension of an oropharyngeal tumor into the anterior pillar or oral cavity, or ipsilateral 1A and 1B for the oral cavity tumors. Same way, these are the same guidelines which you follow when you do neck dissection. And if there is a PN1 or N2, N3 disease, then uninvolved ipsilateral level 1B and 4A is taken. Ipsilateral, lateral, you can go through these slides later on. These are the same principles which you follow when you do the neck dissection. So just to conclude, indications, what are the indications? So definitive indications of giving post-operative radiotherapy are if this is T3, T4 tumor, N2, N3 disease, if there are closed margins. Definitive factors for adding adjuvant chemoradiotherapy are ECE positivity in the node, or if there is a positive margin. And there are certain factors which can influence our decision if this patient should be given adjuvant radiotherapy are if there is PNI positivity, lymphovascular invasion positivity, if it is a worse grade tumor, single node positivity, or worse pattern of invasion. So first question I have already answered. Addition of concurrent chemotherapy is given if ECE positive or margin positivity. So optimal dose is 60 to 60 gray in 30 to 33 fractions for high risk patients, and 50 to 20 gray to 25 fraction equivalent is given for elective nodal coverage, Optimal timing of starting post-operative radiotherapy is preferably less than or equal to 6 weeks following the date of surgery, and we should follow target delineation by taking all pre-op clinical and radiological findings into consideration. Thank you. We can have question answers if there are any.
Dr. Patel, thank you for delivering this talk. I want to take this opportunity to not only express appreciation towards you. Guys, Dr. Anshul has been part of our dynamic radiation oncology team for a number of years now. And I would encourage you to ask questions. I think she gave you a very lucid and basic presentation on basic indications and how we approach the issue of giving adjuvant radiotherapy in oral cancers. She hit the nail on the head when she mentioned the Bernier-Cooper studies and the pooled analysis that followed. It's extremely important that we realize the indications and not over-treat these patients. Of course, appropriate treatment would be the norm. But I'm going to hand over to the meeting host, and you guys should make sure that there are some questions.
Good morning, ma'am. Ma'am, this is Ajay, ma'am.
Yeah, Dr. Ajay. Thank you, Dr. Shamit. If there are any questions, like we can take them, or we can take it after Dr. Arpita's talk also.
I feel.
Yeah, I think Ajay, I think I got disconnected in the middle, but I think the basic points have been highlighted very well by Dr. Anshul in this. I'd encourage questions. I think you're beginning to get them in the meeting pane, so I'll not hold further. I think that we should take questions on adjuvant radiotherapy right now because the two topics are so different from each other, and we'll take Arpita's questions after her talk.
Okay. So there is one question regarding T1, T2, N1 tumors with PNI negative. If high quality what is the primary site? Like, are we talking about oral tongue? If it is buccal mucosa, if it is alveolus, a lot will depend on that also. Dr. Subhashish has asked this question. Dr. Subhashish, are you mentioning which site it is? Which site actually it is?
I guess what he wanted to convey is most likely precise to the tongue, I feel, ma'am.
Yeah, if it is tongue, if it is T1, T2 and N1 tumor, I would be, I will see, like if it is a young patient, I will be keen on giving radiotherapy to this patient because it is a, as I mentioned, that this is not a concrete indication of giving radiotherapy, but if it is a young, if the grade of the tumor is more, if worse pattern of invasion is there, and if it is T1, T2 and N1 tumor, I will be giving radiotherapy in this patient because oral tongue is, they usually behave very bad. They are pretty aggressive tumors. And if it is buccal mucosa, T1, T2, N1, like we can well lateralized tumor, if it is grade 1, PNI negative, then we can like observe also.
Hi, ma'am.
Hi, Dr. Raman Hanji.
Hello. Yes.
Question?
So, ma'am, what is your philosophy on the altered fractionation schedules? Like, I mean, the hyper fractionation or accelerated? I mean, what's your experience on it?
Actually, as we have seen that accelerated fractionation is given in order to shorten the overall treatment time. However, in Indian setting, it is very difficult and it is very toxic also because patients need to come 2 or 3 times a day. So it's not feasible in our setting where people are finding it difficult to come to the hospital even once. So we have like we don't give accelerated or hyperfractionation in our patients. Indian setting, mein most of the centers are not giving. They are most of the centers are giving conventional fractionation only. Even in radical setting, I'm telling, post-operative is even difficult to tolerate.
The next question one of our student have asked is there any evidence of supporting adjuvant in Devoi and T2 lesions? This was based on Abrahami's paper, I guess, ma'am. Where
actually, DOI, you are talking in tongue or buccal mucosa? Because tongue DOI has already been incorporated in the staging now. So usually T2, if it is more than 5 in oral tongue, we give adjuvant radiotherapy as a like hospital protocol. We take these patients for radiotherapy. However, like 5 to 10 is a gray area. We may, it's a debatable thing, but our hospital policy is to give radiotherapy, adjuvant radiotherapy, if depth of invasion is more than 5 mm in tongue, oral tongue. PNI in small nerves is not an indication to give radiotherapy. If PNI is positive in named large nerve, major nerve, and if like there also there are a lot of things which we need to check, whether less than 1 mm nerve is involved, if it is nerve diameter is less than or more than 1 mm, whether it is a named nerve or an unnamed nerve, if cut margin of that nerve is positive or if cut margin of that nerve is negative. So if it is intratumoral or extratumoral, if nerve positivity is there in the lymph node or within the tumor. So all these things are important. If this is a PNI in a small nerve and unnamed nerve, and rest of the things are like, if it is a T2, T1 tumor, then I don't think adjuvant radiotherapy should be offered until or unless we are talking about oral tongue. Is there any role of BG scoring decision making regarding adjuvant? What is this BG scoring?
Ma'am, this is based on that this thing, worst pattern of invasion. How do we document, ma'am?
Okay.
Actually,
as I mentioned, alone is not a criteria to decide if we give radiotherapy or not. If worst pattern of invasion is 3 in, see, oral tongues, in oral cavity also, tongue is the site which behaves very aggressively. If all these features like relative indications of radiotherapy are present in oral tongue, and if one or more than one risk factor like PNI positivity, if LVI positivity along with worst pattern of invasion of it is grade 3. So if all these parameters are present in oral tongue, then I would be like giving offering adjuvant radiotherapy. But if it is there in buccal mucosa or alveolus, then I will not adjuvant radiotherapy in these patients. Worst pattern of invasion alone is not a criteria to offer adjuvant radiotherapy. As of now, there is no indication. As of now, there is no indication to say like this patient should be offered radiotherapy on the basis of this.
I think, but BG, ma'am, BG scoring includes some of the other parameters also, like I think the perineural invasion also, and the LHR ratio also. So
I have I have no idea about this BG scoring system. I will have to check, but as of now, there is no as of now, like we cannot decide on the basis of these scoring systems that we should be offering. I have mentioned all the indications of adjuvant radiotherapy and concurrent chemoradiotherapy. Rest all are relative indications, like patient to patient vary karega wo. Like patient. Yeah.
Could I make a comment to this?
Yeah, Dr. Shamit. This scoring system, I'm not aware of this BG scoring system.
Yeah, understandable. I like the trend in which everyone who's asking questions in the chat box are actually investigational topics. We'll get answers to this as we go on. Regarding Brandwein, MSKCC, and other scoring systems, they are essentially pathological prognostic tools which help you predict whether or not adjuvant therapy should be given based on that criterion. Like Dr. Anchal mentioned, in the absence of other adverse prognostic factors, the significance of these in isolation has not been studied well enough. The only exception to this is PNI, as she is already elucidated very well, and DOI, which is also elucidated with inputs from Ajay and a couple of other people. One point I noticed Suhasis's initial question about a well-performed neck dissection. Remember, Suhasis, that there are criteria for defining a well-performed neck dissection. The British Academy of Head and Neck Oncology has a nice paper on adequacy of neck dissection. There are other papers that have followed since that time. So when you mention a high-quality neck dissection, make sure that you're using more standardized nomenclature. I think Anulis's question was also very relevant, which has already been answered. BG scoring, we've talked about investigational topic for the future. DOI, Ibrahimi, ICOR. Remember, Rithin, that there is data for even 1 millimeter, 2 millimeter, 3, 4, and 5, and so on. Yes. But as an institution, you have to adopt, in discussion with your adjuvant oncologists, you have to decide whether or not you are going to adopt a certain criteria, or you're only going to follow HSCC and go with 1 centimeter. We realized, based on retrospective data in our patients and a couple of papers that we presented, that 5 millimeters seemed to be the cutoff. At that time, incidentally, the ICOR study also came out, and that also showed a better DFS with adjuvant therapy in 5. So we follow 5. I think the data is getting more and more elucidated as time goes on. But then again, any institution can pick up their criteria based on their interpretation of evidence. Yeah. Thank you once again, Dr. Anchal.
Welcome.
Ma'am, just 2 more questions, ma'am. Ma'am,
Yes.
if there is a major nerve involvement, for example, to say if it is a mandibular nerve which has been involved at the cut segment or lingual nerve, so what will be our extent of adjuvant, ma'am? Should
See,
will it go up to the skull base, ma'am?
Yeah. So if it is a named nerve, like mandibular nerve you are telling, so we have to see, there are 2-3 things which since this is a surgical platform, 2-3 things which I would like to ask you to name while you send the surgical specimen is: one, if there is a nerve you are sending, please name the nerve so that pathologist can give us whether it is a named nerve or unnamed nerve. Then, as you asked, if it is a named nerve and if it is positive, then in that case, post-operative MRI also we get it done as a part of planning in order to see if there is a gross nerve involvement post-operatively also. And there we trace the nerve up till the base of skull. Like we take all the foramens and all also. And there are certain guidelines which we have to follow, like if it is a small nerve, how much margin we have to take. Like usually we follow it up to the base of skull. If it is a named nerve and if it is positive. And if cut margin of that nerve is positive, then also there are indications, then there are target delineation guidelines which we follow when we take. That is why we emphasize that please name it while you send the sample so that pathologists can tell us ki, this is the named nerve and this is positive. But when we get PNI positivity in small nerve, or like as if you would have seen that we are getting histopathology report. Now they have started giving us if it is a small nerve, if extensive involvement of that small nerve is there or not, if margin of that nerve is positive or not. So based on all these criteria, there are target delineation guidelines which we follow. And in most of the cases, we go up to the base of skull in these cases if PNI is positive.
And second thing was,
yes.
Regarding breaks during radiotherapy, ma'am. For example, to say due to toxicity, when there is a break, how do you handle that, ma'am? What will be the thing?
There are calculation models. Like we calculate gap correction. Like if there is a gap of 10 days, there are certain formulas by which we calculate if 10 days gap is there, how much extra dose we need to give in order to compensate that. So we compensate by giving extra dose to those patients by using those formulas. Like if there is a 20-day gap, how much dose would have decayed, and that particular dose we add in the total dose in order to compensate for that gap. Like if there is a 15-day gap, and as per the formula, it tells us that you have lost 3 gray dose benefit by those 15 days gap. So we add those 3 gray after the end of the radiotherapy. So by calculating that, we add extra dose to compensate the gap.
Okay, thank you. I think
if every other criteria for adjuvant is negative, but the bone that we excised and it was a marginal mandibulectomy shows to be involved. But this will make it T4
positive.
4.
In these kind of situations, it is better to, if it is re-resectable, to go ahead and re-resect instead of.
But make T4A tumor. So for like it will be an indication to give adjuvant.
Yes, ma'am. But if it is margin positive, then the patient will require chemo also.
Yeah.
Can I help address this this question, Ajay, with Dr. Anchal's permission?
Yes.
Yeah.
Yes, Dr. Shamil.
So first of all, I think it's a relevant question from Sanjog again. I think that if it's dental socket erosion and your margins are negative, I think Sanjog alluded to bone positivity, not margin positivity. So if it's dental socket erosion, you might, in discussion in your tumor board, decide to observe that patient if the margins are freely negative and it was a small T1, T2 tumor. But like Dr. Anchal mentioned, if the alveolar bone is involved, there is no data that alveolar bone post-marginal mandibulectomy, whether or not there's going to be an improvement in survival criteria with adjuvant radiation. That being said, we'll all lean towards giving radiation therapy for the simple reason that if it were PT4A to begin with, and if it was not a histological surprise, you would have anyway given radiation therapy to
उनसे पूछो कि
Yes.
कॉन्स्टिपेशन वगैरह तो नहीं है और कोई प्रॉब्लम किसी भी तरह की, वो पूछ के फिर मेरे को फोन करो बेटा, ठीक है? ओके.
Shamil sir, can you come again? I didn't get it actually. I didn't understand.
So what I was saying, Sanjog, was that there are two scenarios here. Actually, three scenarios. The first scenario is margin positivity on the bone. If the bone is margin positive, then as Ajay said, you will re-resect, and that patient will definitely get adjuvant therapy. If you have a margin negative bone resection, and I'm only talking about bone margins here. If you have margin negativity, but it is only dental socket erosion, which makes it a T3, you might decide to observe some of these patients and give some adjuvant therapy based on your tumor board consensus, because data is currently not sufficient on that topic. The third criteria is if you had cortical bone invasion, in that case, it means that we've probably chosen the wrong surgery for that patient. But if margins are negative and if residual alveolar bone has enough stability, then I would offer adjuvant therapy to those patients. Is that clear now?
Yes.
Okay. I think if there are no other questions, maybe Ajay or Raman could choose to move ahead after thanking Dr. Anchal.
I think there is one more question regarding the accelerated fractionation with concomitant boost. What is the indication? Dr. Sebashish, as such, there is no indication to use accelerated fractionation with concomitant boost. We can take any, we can choose any patient for any fractionation thing. We can like as such, there is no indication which patient to be taken for acceleration fractionation. Any patient can be taken for any fractionation schedule depending on their institutional protocol. I think there is no question.
Yes, ma'am. I don't think so. There is a question, ma'am.
So we can move ahead to Dr. Arpita's talk.
Yes, ma'am. Thank you, ma'am. We
Thank
can
you.
move ahead with Dr. Arpita's talk, ma'am. If there is any questions, maybe after that we can take
Okay,
over.
sure.
Thank you so much, ma'am. Yes, ma'am.
Thank you.
Dr. Ajay, shall I start?
Yes, Dr. Arpita, you can. Sorry.
Good morning, everyone. Our topic for today's talk is prosthetic rehabilitation of head and neck cancer patients. Among head and neck cancers, oral cancer, it ranks 5th among the most common cancer worldwide. 2.5 lakhs new patients, they are diagnosed in India alone, and among them, 3/4 are in the advanced stage. Oral cancer care has ceased to be merely cure-oriented treatment, such as ablative surgeries, radiotherapy, chemotherapy, etc., which results in various residual deformities and dysfunction. Taking into account the prevalence of functional and cosmetic deficits, there is a need for patient-centric approach for addressing every aspect of their problems. Therefore, rehabilitation is an essential phase of cancer care. Nowadays, hospitals are becoming the centers for comprehensive healthcare. Complete rehabilitation of head and neck cancer is achieved using multidisciplinary approach. It involves several specialties like maxillofacial surgeons, oncologists, prosthodontists, oral pathologists, radiation therapists, etc. Patients may have different rehabilitation needs throughout their care pathway. Therefore, rehabilitation with a complete and comprehensive treatment plan should be considered from the time of diagnosis itself. Now, we'll be discussing about the role of maxillofacial prosthodontists in detail. First of all, maxillofacial prosthesis is the art and science of anatomic, functional, or cosmetic reconstruction by means of non-living substitutes of those regions in the maxilla, mandible, and face that are missing or defective because of surgical intervention, trauma, pathology, or developmental or congenital malformation. Aims of restorative dentists are restoration of aesthetic, restoration of function, protection of the tissues, and psychological support of patient. This figure shows how maxillofacial prosthodontists is involved at various stages in the treatment planning and rehabilitation of head and neck cancer patients. How pre-operative, per-operative, and post-operative roles are performed by the maxillofacial prosthodontist. We'll be discussing in detail about the pre-operative consideration. It includes 4 goals. First is the psychological support. Counseling the patient and their spouse, family, caregivers concerning the various stages that will be taking place during the prosthetic management. Then the dental management, which includes oral prophylaxis, management of acute infections of oral cavities, extraction of the teeth that may compromise the surgical area, restoration of the teeth that need to be retained to support the forthcoming oral appliance. Pre-operative impressions are taken. And last, but the most important one, is the suggestion for the surgeon. Now, you must all be thinking that what a prosthodontist can suggest to a surgeon regarding the surgery. So we'll be discussing that in detail. Surgical enhancement and the suggestions for the surgeon. If the extent of tumor permits, then we must work on preserving the hard palate and the preservation of the ipsilateral premaxilla. Prognosis, it improves dramatically by saving teeth on surgical site because the functional fulcrum line shifts to a more favorable position. As many alveolar processes and teeth should be preserved. Again, I am emphasizing here without compromising the complete removal of tumor. Only if the extent of tumor permits, these considerations should be followed. When one maintains anterior alveolus and the floor of nose, there will be less collapse of facial form and less post-operative contracture. Attachments of muscles of facial expression will also be preserved. Another important point to mark here is from where the line of resection should be made. It should be made through the socket of extracted tooth, not between the roots of adjacent teeth, because if the line of resection is made very near to the root of adjacent teeth, then it is going to compromise the health of the tooth, which is going to be the abutment for the retention of the prosthesis in future. So these figures, they show how the fulcrum line shifted to a favorable position just by saving the teeth on the defective side. If not all the interiors, even at least saving a central incisor on the defective side will help in shifting the favorable line to a favorable position, this fulcrum line to a favorable position. Because our prosthesis, which we delivered, they rotates along the cut edges of bony surfaces. Many practitioners, they think that third molar has no clinical use and thereby they remove that part of maxilla during tumor resection. But that's not the case actually. We save third molars on, if we save these third molars on the ipsilateral side, then these molar will be a great help in retention. Like just clasping these third molar on non-defective side, it prevents the tissueward movement. And while clasping the central incisors and the third molars of the defect side, they prevent the downward rotation of the prosthesis. Now, types of the maxillofacial prosthesis. Broadly, it is classified into two parts, intraoral and the extraoral prosthesis. Intraoral prosthesis, which are used to restore the portions of the oral cavity and the nearby anatomical structures. It comprises of obturators, speech aid appliances, and guiding prosthesis. Extraoral prosthesis, they are used to return the patient's appearance to an acceptable aesthetic state. It comprises of nasal, orbital, ocular, and facial prosthesis. By no means should a prosthetic restoration be considered a substitute for the plastic reconstruction, but in certain circumstances, it may be an alternative. Now, the challenges a prosthodontist meet in the prosthetic rehabilitation. First and foremost is impression making. Challenges in recording impression in a maxillofacial defect is recording the impression in a static imprint of tissue bed without taking account tissue movement during function. Other challenge is to gain the retention, stability, and support. Retention can be taken in the form of anatomical and mechanical ways. Anatomical, as we discussed, by slightly modifying the surgical modifications to take the retention from the remaining teeth, hard palates, soft palates. Retention can also be taken from lateral scar band. And in cases of unfavorable defects, even anterior nasal aperture works as a great aid in giving the retention. Mechanical support and retention can be taken from clasps, magnets, implants, and few adhesives. Other challenge is of giving functional rehabilitation. So maxilla, as we all know, it plays a critical role in speech, swallowing, and mastication. Therefore, reconstruction of maxillectomy defects, they are particularly challenging for the head and neck reconstructive surgeons. Also, post-surgical maxillary defects, they predispose the patient to hypernasal speech, leakage of fluid into the nasal cavity, and impaired mastication. Other challenges about the aesthetic post-maxillofacial surgeries, like after the maxillofacial surgery, the dissected site, it leads to the loss of continuity and it causes the disfigured appearance, which causes psychological burden for the patient. Lastly, maintaining the longevity of the prosthesis, like improvements in the prosthetic material properties, including color stability, durability, they all are needed to increase the longevity of the prosthesis. Materials commonly used in the fabrication of maxillofacial prosthesis in past, silver, gold, iron, wood, leather, etc. were used. Currently, silicons and acrylics are the most used materials for the maxillofacial reconstruction. And in future, newer techniques have come into the market, like taking digital impressions and processing them, engineering them with the help of computer-aided designs and manufacturing, which helps in giving a better fit to the prosthesis. Now, coming on to the intraoral defects and prosthesis. These are the classification of the maxillectomy defects. The class 1 defects, they are the most frequent defects. Most patients, they fall into this category. Class 2 defects, they are the most favorable one. The reason is same, we discussed, because the fulcrum line is shifted to the defect side. So the prosthesis which we give in such cases, they are with good retention, stability, and support. Class 3 defects, the design for these patients is pretty much simple, and retention and stability can be effectively planned in such cases. Class 4 defects, they are little difficult to restore because of the lack of the supporting structure which aids in the retention. Class 6 defects, these are actually rare. They occur mostly in the trauma or congenital defects rather than a planned surgical intervention. Now, indications for the obturator prosthesis. Obturator prosthesis can act as an interim prosthesis by bridging the time between to secondary surgical reconstruction of the defect. They can be indicated in cases of large maxillary defects. If there are any surgical failures like heavily scarred palate, or there are large multiple perforations. When patient is susceptible to recurrence of the original lesion, which produce the deformity, or when the local avascular condition of the tissue, it contradicts the surgery. Functions of obturator, it helps in closing of the defect, enhance the healing of traumatic or post-surgical defects. It improves the speech and aesthetics, prevents regurgitation of food from mouth, improves deglutition and mastication, and it prevents the flows of exudates in the mouth. So obturators are an easy approach for the rehabilitation of head and neck cancer patients, depending upon the material they are made up of. They can be made up of the resin, cast partial metals, and the silicon ones. For the patient with maxillectomies, there is usually a 3-stage management procedure recommended. First is the placement of surgical obturator, which is at the time of surgery, and it to be retained in place for 10 to 21 days or until the first level of wound healing occurs. Other is the placement of interim obturators after 3 to 6 months, and then the placement of definitive obturators after the wound healing is confirmed after 6 to 12 months period. Now, surgical obturators in detail. Surgical obturator itself is divided into 2 parts, like they can be immediate, which are inserted at the time of surgery. They can be delayed, which are inserted 7 to 10 days after surgery. So the clinical considerations for surgical obturators are, first of all, a primary cast is obtained before surgery on which a mock surgery is performed. Clear acrylic plate is generally preferred for the surgical obturator so that the inner wound can be easily seen through it. If a patient is dentulous, retention is obtained with the clasp. If the patient is edentulous, the obturator is wired into the alveolar ridge and zygomatic arch. Anterior attachments with the wire from labial frenum to nasal spine may be used. Usefulness of surgical obturator is as it allows the careful packing of wound site. It keeps the food and debris from getting into the wound. It allows eating, drinking, swallowing without a nasogastric tube in place. It improves the quality of life of patient by allowing immediate oral communication with the family, surgeon, and prosthodontist. In this picture, you can see there's a large maxillary class 4 defect present, and the surgical obturator was inserted into like 10 days after the surgery. On one side, the retention is taken from the teeth, and the other side, the obturator is sutured with the soft tissue for the better retention. Interim obturators. The design typically follows the basic principles of the removable partial dentures. It may include the placement of the teeth in the visible area. We can like replace few of the anterior teeth, which aids in the patient better aesthetics. Office visits are to be scheduled regularly to correct the minor tissue irritation because the healing is continuously happening. So minor tissue irritations, and as per the healing is happening, the prosthesis need to be adjusted. So regular office visits are required. Dental care of existing teeth must also continue to be monitored during this interim appliance period. In this patient has a class 2 maxillary defect, and you can see how obturator is placed, and it properly helps in sealing the palate area, which will help the patient in proper swallowing and speech. Definitive obturators, they are of two types, hollow bulbs and roofless. This bulb is given, it's a special technique to decrease the weight of the obturator in the defect area. When to give the definitive obturator, the timing, it actually depends on the size of the defect, the progress of healing, effectiveness of the present obturator, and the prognosis of the tumor control. Now coming on to the mandibular defects. Mandibular defects occurs generally after the surgical resection involving the mandible, floor of the mouth or tongue, which leads to the mandibular discontinuity defect, further facial asymmetry and malocclusion. If condylectomy has been performed, it leads to deviation of mandible towards the defect side and inferiorly due to the pull of suprahyoid muscles and loss of ligaments of temporomandibular joint. Main treatment objective in hemimandibulectomy cases is to re-establish an acceptable occlusal relationship for residual dentition. Various prosthesis design are there, either mandibular based or palatal based, in order to establish the occlusion. In mandibulectomy cases, the prosthetic rehabilitation should be started as soon as possible, 2 weeks after surgery, to limit the deviation of mandible. Because once the wound heals and the contraction happens, then it is very difficult to pull back the mandible to the normal centric position. So now we'll discuss about the mandibular guiding prosthesis. The mandibular guiding prosthesis can be given to restain the patient's neuromuscular system to provide an acceptable maxillomandibular relationship of the residual portion of the mandible, which permits the occlusion of remaining natural teeth. Guide flange is extended into the maxillary buccobuccal fold superiorly and diagonally on non-defect side. These guiding flange prosthesis can be regarded as just a training type of prosthesis. If a patient can successfully repeat the mediolateral position, the guiding flange prosthesis can often be discontinued, and some patients, however, may continue indefinitely with the guide flange. So this is one of the case in which the segmental mandibulectomy was performed and deviation of mandible towards the defective side. So guiding flange prosthesis is placed, and you can see how beautifully the upper and lower teeth, they have come into occlusion. You can see while closing how this guiding flange, it pulls the mandible towards the non-defect side. Our other case, in this patient also, segmental mandibulectomy is performed on the right side, and which leads to the division of mandible towards the right side. Again, a guiding flange prosthesis is delivered, which aids in the pulling back the lower teeth into the occlusion with the upper teeth. Patient can properly chew on it. Now, maxillary ramp guiding prosthesis. Design: the occlusal surface of lower teeth glides freely over the slope of balancing ramp, minimizing the amount of deviation during mandible closure. Principal objective of prosthesis: it is to re-educate the mandible muscles in achieving the correct mediolateral relationship along with the maintenance of the aesthetics and the function. Similarly, segmental mandibulectomy was performed, which lead to the malocclusion of the teeth. Maxillary ramp prosthesis was delivered, and the teeth came back to into the occlusion. Now, mandibular rehabilitation with the implants. Implants, they are used both in intraoral and extraoral defects, and they have significantly improved the restoration of both the form and function of oral and craniofacial region. What are the characteristics of the successful osseointegration? The implant should be of biocompatible material. Non-traumatic aseptic surgical procedure should be there. Initial healing period in which functional loading of the force is deferred. Before the implant placement surgery, a healing period of 4 to 6 months after performing the reconstruction surgery is necessary. This period should not be overextended to prevent the graft resorption. I would like to conclude my talk with few points. Like, oral rehabilitation is an encompassing component of the treatment of head and neck cancer patient and is a major contributor to enhance the quality of life of cancer survivors. Maxillofacial prosthodontists should be an integral part of a team of consultants in diagnosis, treatment planning, and treating jaw irregularities and deformities. Without a highly interactive and dynamic dialogue among healthcare providers during initial treatment planning process, efforts to provide the optimal rehabilitative care are impaired. Evolving trends and skills have helped the patients to overcome need for the additional surgery. The result achieved from the prosthesis are often aesthetically pleasing, functionally acceptable, and from patient's perspective, it is less traumatic than the plastic surgeries. Although normal function cannot be achieved, but yes, the attempt to accomplish the optimum functional outcome by prosthesis is definitely helpful for the patients to maintain a normal life. Thank you, everyone.
Thank you, Arpita. Nice talk. Any questions?
Dr. Achyut, in edentulous maxilla, the retention is taken from the tuberosity area. Likewise, I mentioned the retention is taken from the hard palate, soft palate region, or if there is any lateral scar band, we take support retention from that area. If you have to give the surgical prosthesis, surgical obturators, they can be sutured to the zygomatic area. And if you are planning for the definitive or interim obturators, then by that time the healing has happened and you can take support of the lateral scar band and tuberosity region. If tuberosity area was compromised in the surgery, you can take support of the premaxilla area. They both aid in the retention. Yes, as I mentioned, if there are any surgical failures, the obturator can be given in such cases also. Like the case which I shown to you, I'll again display it. This patient also got the temporal flap done, but because of the recurrence, we have to again perform the surgery, and after this, the surgical obturator was placed.
Sorry to interrupt, Dr. Achyut. If your question is pertaining to say that if there is a temporalis flap in situ, and with that can we deliver an obturator? If that is your question, I think yes, it is deliverable. Only thing is the opposite side of the R should be intact so that the retention can be taken through that.
No, but Dr. Ajay, if temporalis flap is already there, so until and unless there is no perforations in it, Obturators are not recommended.
No, the question what he wanted to convey, if I'm right, what he wanted to convey is not only the obturator with the dental teeth
Okay,
also.
prosthesis. Yes.
Yes. That was his question.
I think there are some questions from the previous talk as well.
Yeah.
Dr. Sohasis has asked a arrest trial.
Yes.
So what I mean, Dr. Sohasis, what's your question on the arrest trial?
I think he wants to ask in T1, T2 tumors, if only PNI is present, whether adjuvant radiotherapy should be given or not. I think that is what he wants to ask.
So
this trial is ongoing. That is what I have been mentioning since the beginning. Like if these relative indications are there, then we have to follow our institutional protocol. Like as I said, if it is a T1, T2 tongue tumor and if depth of invasion is more than 5, then we give adjuvant radiotherapy. If a T1, T2 tumor with PNI alone is there, then I will see other risk factors as well in those patients. If only PNI in a minor nerve is there, then I will not give adjuvant radiotherapy. But if there are other adverse features are also present along with PNI, then I may take that patient up for radiotherapy. Can I share my screen again? Because there are a lot of questions regarding PNI.
Yes, ma'am, you can share.
Yeah, just a moment. Let me share. Yeah. See, visible?
Yes, it's visible, ma'am.
So that is what we follow. I will share 2-3 papers. One is that is how we decide if PNI is present or absent. If PNI is present, we categorize this PNI into bad or ugly depending on these risk factors. Like if it is focal, if it is a small nerve, if it is a microscopic PNI, and if it is intratumoral, then we categorize into a bad. If it is extensive, if it is involving large nerve, if it is gross, if it is radiologically also visible, or if there are clinical features also suggestive of cranial nerve involvement, then we categorize it as ugly. If it is bad PNI in isolation, alone, it is not a well accepted indication to offer post-operative radiotherapy. That is what your question was. Like if it is PNI alone. So PNI is not an isolated criteria. We see if it is a bad PNI or if it is an ugly PNI. If bad PNI alone is there and rest all is okay, then we may just observe the patient. If it is an ugly PNI alone, then detailed clinical examination is required, then discussion with pathologist to find out if it is extensive, if it is gross, if margins of the nerve are positive. Then we review the pre-op as well as post-op MRI, intra-op findings, and after discussion in multidisciplinary tumor board, then we say whether we should take this patient up for radiotherapy or not. So this is, as of now, it is a relative indication, but we decide on the basis of all these factors.
Yeah, I must say this is a great encapsulation slide. Thank you, Anchal. Also reminds me of the Hollywood classic, The Good, Bad, and the Ugly, right? So I think to Sohasis and all the other participants, it's extremely important that we realize our responsibilities before we start asking our adjuvant therapy specialists about giving it. Remember that she already pointed it out to you during her presentation that you have to tag your nerves. And sometimes even us at our institutionalized place forget to do that. Remember that after the resection, you should spend about, and this is for the head neck oncologist in training, you should spend about 10 minutes with the specimen, tag the nerves, tag the bony margins, do any mucosal orientation that is required. But specific to PNI, please tag the nerves, because only then will the pathologist be able to tell you whether it is a major nerve trunk PNI or otherwise. There's no point not doing what we are supposed to do and then eventually expect something to magically appear in a histopathology report and also to get discussed in a multidisciplinary tumor board setting. It's not going to happen. So make sure that in the exciting literature that's emerging with PNI and whatever we already have, you can only expect cogent decisions if we do our bit. So make sure you tag major nerve trunks. Make sure that you send margins. Even if you're not tagging, then take that proximal nerve trunk and send a margin, so that we know that there was no PNI, especially in skip disease, especially in salivary gland malignancies and everything, where we know that there are skip lesions.
There is one more slide to Dr. Ajay's question, which he asked, like if nerve is positive, then how do we go about it? So we define the nerve involvement into 3 zones. Like there is a paper which tells us that we have to categorize, we have to divide each nerve into zone 1, zone 2, and zone 3. And that is how we take it into our target delineation, like depending on if zone 1 is to be taken, if zone 2 is to be taken, or if zone 3 is to be taken up to the brainstem, depending on the pathological and clinico-radiological features. Then these are the cranial nerve contouring atlas for us, which tells us if this is it's more like maths. If this thing is there, then we have to follow this. If this thing is there in the histopath, we have to follow this. So there are guidelines available which guides us how should we go about it. And regarding the dose, again, this is a very good paper which tells us on the basis of all those risk factors which I just mentioned in the previous slide. If it is a microscopic focal intrahumeral PNI, then this is the dose which we should take. If it is a more positive margin along the nerve, then we should also consider giving chemotherapy, which is again a relative indication, and this is the dose which we should follow. If it is a gross disease or PNTS on imaging, then this is the dose. So there are certain guidelines which guide us in PNI also. So PNI is a very extensive topic, and a lot depends, as Dr. Shamit mentioned. Then tagging of the nerve is important when we are sending the specimen. And if a pathologist tells us, then this is the nerve, then there are guidelines which we follow when we give adjuvant radiotherapy. So you can read these papers if you are interested. These are very good papers which tells us how should we go about it.
Any other questions?
Dr. Aman?
Yes, sir.
Yeah, just wanted to address whether I was signed out for a little bit in between. Whether
yes, sir,
Dr.
you were
Arpita,
signed out. Yeah.
So whether Dr. Arpita was able to, great presentation, by the way, Arpita. So I'm wondering if we covered the prostheses that are specific to oral cancer, like lip plumper prosthesis and the prosthesis that we sometimes use and call her expertise for. Was that discussed?
Yes, sir. Implants were discussed, and the obturators were discussed in detail, and guiding prostheses were discussed.
Okay, great presentation. Thank you so much. And I hope everyone benefited from this as much as they could have.
There is one question regarding brachytherapy in early stage carcinoma lip. There is a role of brachytherapy in carcinoma T1, T2 lip. If it is well lateralized, not crossing the midline, and if we are expecting neck is not to be addressed, then we can take up the patient for brachytherapy. But brachytherapy option is not available in many centers these days due to lack of expertise. And probably we are getting better results with surgical techniques. So this is an option, but it is a less explored option in India as of now. Even in early tongue, brachytherapy is an option. But as we know that tongue is an aggressive tumor, there also very selected patients are taken up for brachytherapy, be it lip or be it tongue.
Yeah, I think the additional disadvantage with brachytherapy for tongue is that you have to address the neck separately.
Neck also, yeah, that is what.
Because as data has become so elegant, and we now know that any tongue cancer, even T1 tongue cancer, is associated with with a significant proportion of micrometastasis in the neck. I think brachytherapy for oral tongue, if I hope Dr. Anshul that you agree, is probably more or less obsolete. Also because we can do better reconstruction with the tongue. But in lip, I think it's still a probably relevant question which Gaurav asked, because it's impossible to restore the exact cosmesis of the vermilion and of the vermilion skin interface. And also the propensity of lymph node metastasis is low in T1 disease.
Very less.
Yeah. So Professor D.N. Sharma, again, thanks to you, we've had him at a couple of our meetings in the past. I think he's published on brachy in lip cancer. Maybe our take home should be to the participants to read about it and then discuss it in their respective tumor boards on a case-to-case basis.
I think I'll conclude, sir.
Absolutely, Dr. Raman. You're the host. Go ahead, please.
Yeah, so very nice indeed academic presentations by Dr. Anchal as well as by Dr. Arpita. So next week we'll be having a discussion on the principles of salvage surgery in oral cavity squamous cell cancer. That will be presented by me, and there will be a case presentation by Dr. Satyapal. Thank you, everyone.